Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP.
And I'm Moz Calafella, also a Melbourne-based GP.
We'll remind you as always that a podcast can never replace personal advice from your own healthcare provider. But today we're going to be talking about the early signs of skin cancer, what to look for when you're checking over your own skin. Dr Moz.
Absolutely. And before we dive in, we just wanted to say thank you to all the people who've been giving us some feedback around our audio quality. So we've been experimenting a little bit with different setups over the last few weeks. And so we're conscious that some of the audio has not been perfect, and we're working very hard to make sure that that's the case. We really appreciate all the feedback that we've had. It is really valuable to help us make the podcast more listenable too, and hopefully more valuable for you moving forward. So, Dr. Anne, we're talking skin cancers. What are we talking about today specifically with skin cancers?
Well, as you know, our Red Book, which is our Bible as to what we should be doing in terms of screening people, falls short currently of recommending skin cancer checks for all. Yeah, but it does say that from the age of 20, everyone should be educated about skin cancer and be regularly checking their own skin. So today's podcast, we're going to make a stab at educating people in general about what a skin cancer might look like and how they should go about checking their own skin.
I think that is one of the most common questions that we get asked all the time in skin checks, in just normal general consultations. And so hopefully people can find some value from there. So what does the Bible, the Red Book of General Practice tell us about skin checks? How often should people be getting a skin check from a doctor? How often should they be looking at themselves? What should the average person do?
Indeed. So the Red Book says that only people who are high risk should be having regular skin checks with a healthcare professional, but the Australasian College of Dermatologists says very firmly that everyone should be checking their own skin on a 3-monthly basis. And obviously last week's podcast, we talked a bit about how you might decide if you were at increased risk, and anyone who hasn't listened to that one might want to stop and go back and listen. Although, to be honest, I think you can listen to these two podcasts in either order. It will work either way. But anyway, the 3 most common skin cancers are melanoma, basal cell cancer, and squamous cell cancer. And we will talk for interest about what each of these might look like. But the reality is that the skin cancers don't read our textbooks, funnily enough, Dr. Moz. And there might be what a barn door one looks like, but there are lots that don't look like anything that you've seen in a textbook, which is why we've spent literally thousands of hours learning about skin cancer. Literally thousands.
Absolutely. And it's amazing, isn't it, Dr. Anne, like how often you will find some teeny tiny little thing that's subtle, that is just, has some very minor abnormalities and looks nothing like what the textbooks looks like. And then, a few times a year, you will see someone walk in from the door and you're like, yep, that's the thing from the textbook that I read about. Yep, that's absolutely exactly how it looks. But
it's quite exciting to get a textbook one. Yeah, indeed.
It's rare.
So the Australasian College of Dermatologists, who know a thing or two about skin, their recommendations is that every adult from the age of 20 should be checking their own skin every 3 months. The turn of the season, I think, is actually what they recommend, that should be your trigger to, hey, it's time to check my skin. So what would that look like, Moz? How do you even begin to check your skin? What should you be looking at? Which bits?
Yeah, so basically every inch of your skin. And that's why it's really important to do it frequently, because you're covering a large part of you. And so, often when I get asked this question, I sort of talk about as you hop out the shower is a good time because you're already undressed, and you want to find yourself a nice full length mirror, and you want to take a very close look at every bit of skin. Every bit of skin means the skin that's, easily visible, the skin that's hidden away by clothing, the skin that's hiding under underwear and bras. So yes, you can make skin cancers around your breast, around your genitals, around your backside. You want to look in between fingers and toes. You want to look at your nails, inside your mouth.
Under your hair?
You want to under your hair, absolutely. So I've had a run of scalp cancers in the last month or so. That it seems like when it rains, it pours. There's been quite a few of them recently. Where else? On your eyelids, in and around your ears, in behind your ears, basically everywhere. You want to search through every nook and cranny. And I guess the natural question following on from that, Dr. Anne, is what am I looking for?
Very good question. So you're looking for anything that is new or changing or that looks different from everything else that you've got on your skin. And we'll work our way through that. But yeah, new, changing, or what we would call an ugly duckling. And I think that translates easily. Everyone knows what you mean, something that looks like it doesn't belong with everything else. Yeah.
Mm-hmm.
So although the recommendation from the Red Book is that we shouldn't be screening the whole population, the follow-up recommendation is that if you find something that is new or changing or looks different from everything else, then you need to get that checked out by a doctor who knows what they're doing with skin, which is, I think, something we'll be talking about next week. We'll talk about what we do when we see you for a skin check. But yeah, you can check your own skin if you prefer, if you feel you're not high risk. But if you find something, the decision as to whether it's a worry or not, then is very, very firmly the ball's in our court. Yeah, that's not something that we can teach you. And we said we spent thousands of hours already learning all about it, and far from know all the things. I mean, I was very recently in Rome, learning from two of the world experts. And again, every time I go to a conference, I learn new and useful things. Yeah.
Absolutely. It's a forever learning experience, isn't it, Dr. Anne?
It is indeed. So you do need to get it checked out by a doctor, but that doctor actually has to be highly proficient in examining skin cancers, and particularly in using our little light microscope called a dermatoscope. But spoiler alert for next week, we will not dwell on that right now. So will we go straight in with the main worry, melanoma, Dr. Moz? What would a melanoma, what might it look like?
I was about to say, before we dive into that, I think there's another word in there that that's in the Red Book and the Australian College of Dermatology Guidelines, which I just wanted to highlight, I guess, a little bit the sort of ridiculousness of it, which is the opportunistic skin checks. And we often kind of scoff at this opportunistic skin check business. So that's the guideline for everyone that isn't high risk. So, if you don't know if you're high risk or not, go to last week's podcast, listen to the podcast and then do the calculators. But for the average Australian, very few Australians are low risk. Most of us fall into an intermediate sort of risk category. And for all of those people, you want opportunistic skin checks. And the problem is, you go into a doctor for any number of things and your doctor might be excellent. But number one, that doctor is probably busy and they're probably dealing with the thing that you've gone in to deal with. And then number two, they may not have a special interest in skin. And so it's very rare for you to go in for your pneumonia or depression or, your diabetes or whatever the case may be and have them look behind your ears or in between your toes or genitals. They're just not looking there. They're just not looking everywhere. And so you may get some opportunistic examination, but it's unlikely that you're going to get every nook and cranny searched. And that's the tricky thing. And that's why...
Yeah, it is. Yeah, I think it's quite common for us to be listening to a chest or looking in a mouth and literally seeing a skin cancer before our eyes. And I regard that as opportunistic. But I think that patients generally, they're the paying customer. They come to a consultation with an idea of what they want to cover in it. And if you go, I'm not that interested in your list, I'd rather spend at least half of this consultation having a quick look at your skin, you can be rightfully annoyed. Although I'm not sure if maybe we're slightly misinterpreting the Red Book. It did occur to me, because I think the Red Book is saying very firmly that currently Australia does not recommend screening of the entire population, in the way that we do breast cancer screening or we do cervical cancer screening. That currently there's not evidence that it's cost effective to screen every single member of the population. But I wonder if opportunistic includes somebody who's had to think about it and says, I'd actually like to know more about my skin, that they a thinking decision rather than a blanket recommendation that everyone should have their skin check. Yeah. So who knows?
I think that's a very generous way to interpret it, and maybe that's how we interpret it moving forward. I love it. Yeah.
There are murmurings about them bringing in some form of skin cancer for melanoma screening program. Is there not? Was that not come up at the recent Congress?
Yeah, absolutely. Yeah, we heard about that at this year's Congress, didn't we, Dr. Anne? So they're sort of talking about in the next couple of years, talking about launching some guidance around screening the Australian population and what that'll look like. And obviously nothing's in permanent marker yet, but at some point they're talking about screening. I think it was everyone over the age of 30. Is that right?
Something like that. And of course, decisions about who to screen at a population level are all based on cost effectiveness. So it's about the cost effectiveness to treating this population to the health dollar spend. It does not actually translate to you as an individual where there is benefit for you. It's
absolutely.
very much about, does it cost us more to find your melanoma early than it does to find it late? And those are
we haven't had that many episodes of our podcast, but we've already talked about multiple situations where the private fee makes a difference for an individual level, haven't we, Dr. Anne?
Absolutely. So anyway, so the decision whether you're having a skin cancer check is very, very much an individual one, but whether you should be checking your skin is not up for debate. You definitely should be. Someone should be checking your skin, and if you're doing it every 3 months is what's recommended. Right, are we ready to talk? Should we dwell a little bit more, because I said it very quickly, on what people are actually looking for? Because it's lovely to know and interesting to know what the particular skin cancers might look like. But when you're looking at your skin, you have no idea what it is that you're going to find, if anything. So again, can you review for us what actually people are looking for, Moz?
Yeah, so I think probably the key thing is change, isn't it, Dr. Anne? But I often talk about that 3-point checklist, and I sort of modify it
Mm-hmm.
for patients. And so you're sort of talking about something that is a standout mole and like really different from everything else around it. Those are always worth having a look at. Whether something has more than one color, and so if you're sort of seeing, browns, blacks, pinks, purples, reds, whites, all of those things
Mm.
can be interesting for us to sort of talk about or look at. And I think the key one that's really important is if it's changed. And I think you'd had a very interesting note in through there. You can't tell us if it's changed if it's your very first self check. So that makes it really
Absolutely.
important to sort of look regularly. And I think lots of people ask the follow up question, Dr. Anne, what does change actually mean? So maybe you can take that one for us and tell us what changes are we actually looking for.
So change is anything that's different at all. If it's bigger, sometimes if it's smaller, sadly, sometimes it's because it's changed colour or shape, or its borders become irregular. It can be bleeding. It can appear to be swollen or blistered. It can be itching. It can be more scaly than it was before. Literally anything that is different from the last time, that's change. Yeah.
Hmm.
Would you add anything to that, Moz?
No, I think that essentially the word is purposefully vague. It's literally if it
Mm,
wasn't like it was yesterday, then we're pretty keen on seeing it. And I think really importantly as well, just because it's changed doesn't mean that you have cancer and you're going to die. I think
no.
these are reasons why it would be worthwhile looking at it rather than, hey, if you've noticed these things, it's a clear and obvious cancer and you must have it removed. I think that's
Yeah.
the other thing that can
And
sometimes
I
stress
think
people out.
Yeah, I think we talked, I can't remember now if it's last week on the Men's Health podcast, about how we both operate a kind of 4 to 6 week period over which, if you notice something is changing, that you're allowed to keep an eye on it yourself and see how it's going. But if it's still actively changing in any way, shape, or form at the 4 to 6 week mark, we want to see it. Yeah, it then
Absolutely,
becomes, you
yeah.
need to bring it to us so that we can check it out in case it is a cancer. Because some cancers are aggressive, and delaying another few months can mean the difference literally between life and death. So you're
Hmm.
allowed to look at it for about a month or so. And we suggest, well, I suggest, I'm sure most does too, that you actually take a little picture of the spot with your mobile phone. We've all got cameras in our pockets, not so much to remind you where it was, but to remind you when you first noticed it. Because we just get, well, I know I've had this thing, but I have no idea how long it was. But if you take a picture the first time, then it's easy to look back and see, have I had this for 3 weeks, 5 weeks, 6 weeks? Yeah. Yeah.
Yeah, I had a patient yesterday actually who said to me one of the things that I've heard it before, but I think it was just really well timed for this podcast. She uses a 5 cent piece for every one of the moles that she takes. So she'll put a little
Mm-hmm.
5 cent coin right next to the mole, snap a photo, and then that way it doesn't matter how close or far away she is from the camera. She can always zoom in roughly to be about the same size for that 5 cent piece. So I think using something for scale is almost always a good idea. I think
Yeah,
that's a
that's
great
an
move, and it
excellent
means that
idea.
when you show us, we can clearly see without having to guess how far away the camera was or
Mm.
what setting you were in.
Yep. Great advice. Well done, your patient. Yeah.
Yeah, awesome.
Okay. Shall we dive into melanoma?
Let's do it. That's probably the one that's on everyone's mind, isn't it? That's the minute that someone says skin cancer, everyone's brain goes to melanoma, and often you'll hear people say, "My parents have had many melanomas," and then you dive a bit deeper, and actually they've not had any melanomas and other types. But yeah, let's talk melanoma. What is melanoma, Dr. Anne?
So, melanoma is a cancer where there is a proliferation, big words again, of malignant melanocytes. Melanocytes being the cells that in the benign form are just in your moles. Yeah. So Moz talked last week, I think it was, about the control mechanisms going chaos. Your quality control no longer working, and that's how you end up with a melanoma, a malignant growth of melanocytes. There are probably four types, I guess, we're going to touch on. We're going to talk about superficial spreading, which is the most common. There is nodular melanoma, which is the most scary. There is lentiginous melanoma, commonly lentigo maligna, and there is also acral melanoma, which is where you get melanomas on the feet or hands, including affecting the nails, and that's quite rare. Yeah. So melanoma, ABCDs, and in fact ABCDEs of melanoma. Tell us about those, Moz.
Oh, I love a good acronym, Dr. Anne. The ABCDEs. So the first thing that we're looking for is it asymmetrical? So essentially the way my brain thinks about it is, can you fold it in half and make a sandwich? And so if the sandwich is going to have a lot of the filling falling out, then it's not symmetrical. So that's the first thing. And we'll sometimes see asymmetry in one axis or in multiple axis. And so anything that you think doesn't look perfectly symmetrical, we're keen on. The border, is the border regular? And so there's lots of different ways that I think about this, Dr. Anna. Maybe we'll get your 2 cents about border as well while we're talking border. But actually, I'll ask you how you deal with border before I open my mouth and taint your response.
Sure. So for an irregular border, we're simply meaning that the outline is not a regular shape. If you sort of think of things that Mother Nature grows, plants, shrub, bushes, they're not perfectly round or perfectly oval, but there tends to be a balance of like a smoothness to their shape, where they don't have ugly jutting out bits or little bits that look like they're missing. So if something has a very irregular shape, then it doesn't mean it's a cancer, but it means it's a possibility. So that's how I tend to explain it to patients. So think of the harmony of Mother Nature, and if it doesn't look like something Mother Nature would typically go, then maybe we should be worrying about it.
And I'm often torn between giving too much detail and too little detail in this context. And the other thing that I'm glad you didn't mention, but I know that you know, is often that sort of that fading away of the border, or whether there's a difference in how clearly defined the border is in particular locations. So really, any weirdness in and around the border is worth talking about. Color is the third C. So essentially, my brain thinks of it as more than one color. If there's more than one color, we want to see it. And when you're thinking about melanoma, in everybody's head, it's a brown and black thing. Maybe some people think blue, but the reality is any colors are interesting. Any combination of two colors. There are melanomas that you and I have removed over the years that are white and pink, or that are pink and brown, or that are purple and blue. So you can get any combination of colors. D is diameter.
White can be a worrying color, I think, is the other thing that we want to say. Yeah. And the colors are often combined in an asymmetric fashion. If you have something with two colors, but there's one color in the middle and then another color around the outside in a sort of target shape, that's probably less. We still have a little look at it for you, but that's probably less worrying than if it's just all over the shop and sort of unharmonious. Yeah.
Yeah,
sorry,
absolutely.
carry on, Dr. Moz.
No, I think that's a very valuable piece of advice for people. And then D is diameter. So anything sort of bigger than 6 mil is worth paying attention to. And you might look over your skin and go, well, I've got plenty of these things that are over 6 mil. And it's a good opportunity to remind people that just because you have one of these things doesn't mean you have a definite melanoma. These are things that make us want to look at it and decide that it's not a melanoma together. So anything greater than 6 mil, we definitely want to have a little look at. And then the final letter in that acronym, A, B, C, D, E, is for evolving. And so that's, again, down to, is
another
it changing?
Word for change, really, isn't it?
Another word for change, yeah.
They'd already used C, so they thought they'd just grab E and come up with a synonym. So change.
Absolutely. Yeah. And I think the take-home message, really, if you take nothing else from the podcast, today's podcast, is if you have a thing that's changing, we want to see it. That's the simplest way, isn't it? But yeah, so ABCDE is an excellent way to think about melanoma.
It is. And of course, that was designed with the most common version of melanoma in mind, which is the superficial spreading. And the reason that the ABCDEs apply is that these melanomas, for a while, sometimes for some months, sometimes a year or two if you're lucky. It grows only across the surface of the skin and remains very thin before it goes deep. And this period of the change evolving, where it's the asymmetry, the border, the colours, that is our window of opportunity to catch it, diagnose it, and deal with it before it starts invading into the skin, because that's when our troubles start with melanoma. So the A, B, C, D, E's are for the most common variation, superficial spreading, and it is very useful for picking it up.
Absolutely. And these are the ones where often you'll sort of, we've been involved in a few of these over the years where someone comes in and they say, oh, I've noticed it slowly growing over X number of years. They can grow for months or years before they start doing that sort of deep growth. So I think don't be falsely reassured because something's been there for 6 months or 1 year and doesn't already look hideous. So right. I think anything that's changing needs to be seen. Don't make any assumptions around how nasty it is. So, yeah.
I guess for interest, we would say that the stats suggest that the most common site for superficial spreading melanoma in a woman is on their leg, and for a bloke would be on his back. But melanomas can be anywhere, any type of them can be anywhere. So don't think if you're a bloke because your back's clear, then we're good. That doesn't work like that. In an individual patient, the stats are much less helpful, which I think we've mentioned once or twice before in the podcast. Yeah.
There's certainly some recurring themes, aren't there? Starting to sound like broken records, and we're not even that deep into double-digit episodes.
We are not. Number 17, I think. I suppose we'll change the order. I'm getting good at this, Dr. Moz. Because we're in melanoma A, B, C, D, E's, they actually do apply to another subtype of melanoma, although it happens much more slowly. Do you want to talk about that type, Moz?
Are you talking about lentigo maligna, Dr. Anne?
I am indeed. Yeah.
This is actually the stuff of nightmares for me. I hate lentigo maligna. Lentigo maligna, so for the reason I would explain lentigo maligna as the stuff of nightmares is often it mimics those stupid freckles that we find on people's skin all the time, those solar lentigo, which are sort of those really overglorified brown freckles. And lentigo maligna often looks a lot like that, which is why it has that in its name. And again, it is also very, very slow in its radial phase and then suddenly decides that it's going to dive deep down. And so this is the stuff that will often have me looking at the same freckle repeatedly every time I see someone in anxiety, essentially trying to work out, is this, do we need to do something about this thing or not? But yeah, that's my feelings around lentigo maligna.
The superficial spreading, it would be unusual for it to take longer than 2 years from the beginning to become invasive. It can happen, but it would be unusual. But these lentigo malignas, sometimes they can be 10 or 15 years from the beginnings of a tiny little spot to them becoming an invasive melanoma. And they can, because they grow so slowly, even if people are checking their skin, like from 6 months to 6 months, there'll be nothing to see. Maybe if you look at pictures of yourself, maybe 5 or 6 years later, you can see that little brown spot is a tiny little bit bigger. But sometimes at the point of diagnosis, patients can go back in pictures and actually find the tiniest little thing where the cancer now is 10 or 12 years ago in their pictures. And it grows so slowly that you just don't see it. I think it's kind of like boiling a frog, isn't it? That
it is.
The changes that's so small.
Yeah,
slow.
Go on, please.
Yeah, so small and so slow that unfortunately you just don't notice it. So difficult for you, and actually unfortunately quite difficult for us, and we'll probably talk a bit about that next week, about how we try and work out what to biopsy, how our decision making process works for that. So
absolutely.
we skipped over the scary one, or the all scary, but the scariest one, which would be nodular melanoma. And the reason that's scary is that's the one that most people die of still in Australia.
Yeah. And so I guess for people to wrap their heads around, nodular means that it's a lump, there's a nodule sitting there. And the reason that that's one of the scariest is it's often quite quick. And unfortunately, the main thing that dictates what your outcome is going to be is how thick the melanoma is. And unfortunately, the nodulars, because they're lumpy, they might be the size of a match head, but they're already quite thick. They've probably already invaded down into the deeper layers of the skin where they can spread through blood work or lymphatics and cause all kinds of problems. And, unfortunately, because they're quite fast, sometimes they get irritated and bleed. And so you'll hear stories of people treating them with, a moisturizer or a steroid or an antibiotic ointment before someone eventually works out that it's a cancer. And so, again, stuff of nightmares for patients. They make us less anxious because often they're more obviously a cancer if you come and seek assistance from someone that knows what they're doing. but they're very much the stuff of nightmares if you don't get them looked at.
They are.
And so,
And just to explain, the reason that they grow so fast and are nasty so quickly is that there isn't any appreciable phase of them growing across the skin rather than deep into the skin. They go deep from the beginning. It's just a different growth pattern. And the reason why, as a baby skin cancer doctor, you get taught very firmly that all band-aids have to be removed if a patient attends for a skin check. Because the band-aid sign, the patient just has a little tiny bump in their skin that's been bleeding, and they actually don't think they need to show that to you because they think it's just a little pimple or something that's of no consequence. But Professor Rosendahl drummed it into us very, very clearly, didn't it? Band-aids have to be removed.
And it holds true all the time. Like, I think once a month I'll find a little skin cancer under a Band-Aid that someone had said, don't worry about it, there's just a cut or a scratch or a whatever, and it's a clear and obvious skin cancer. So
absolutely. Acromelanoma. Melanoma is on the soles of the feet, palms of the hands, and under the nails. So when you're doing your self-skin check, you have to look all of these places, palms and soles, between the fingers and along the lengths of the fingers and the toes, and have a look at your nails, which is why I get a little bit upset when people turn up with nail varnish on that I can't see through. We'll talk about that next week, how you might prepare for your skin check if you're coming in to see us, but pretty please, no nail varnish. But you need to look at everything. So your own skin check, it's not going to be a 2-minute job. No. Even when you're slick at it, it'll be a minimum of 10 minutes. Anything more you want to say about acromelanoma, other than that it's a thing and you should be checking those areas, Moz?
No, I guess just other than checking, I think the key thing is just make sure that if you are noticing something, please do show it to someone. There are lots of reasons why you can have brown things or pigmented things or coloured things on your fingers, on your nails. And not all of them are bad, but you don't want to be in a position where you've missed finding the bad thing because you were too worried to show someone. So they're difficult even for us. And so share that responsibility with someone else so that there isn't any remorse about missing it.
And we will remind the audience who perhaps didn't know it already, but 60% of melanoma patients have no discernible risk factors. Sure, they have Fitzpatrick 1, 2 or 3 skin, and they live in Australia or New Zealand, but beyond those, which everyone with the correct skin colour has, they have no particular other risk, nothing that made them startlingly at high risk. So although we can predict who is high risk, most melanoma patients don't actually fall into that category, which brings us back to the Red Book and Dr Moz's firm stance that he's not that happy with the bean counters. But
I'll bet most people wouldn't have had Bob Marley as a high risk person when he passed away from his acromelanoma. So I think again, population prediction is all good and well, but we need to think about the individuals as rubbish.
Well. Yeah, absolutely. Okay, basal cell cancers. The most common skin cancer, I think 75% of skin cancers in Australia will be basal cell cancers. There are 2 common types of basal cell cancer, which we'll talk in a little detail, plus there are some rarer versions. In fair skin, and that would again be Fitzpatrick 1 and 2, probably I'm talking fair now, they're often red or pink, but the more natural pigment you have, the more likely is that your basal cell cancers can be dark or will at least have dark spots in them. Yeah?
Yep.
Okay, Dr. Moz, what are you starting with?
So I guess the spiel on basal cell cancers is, I guess they're often slow growing when compared to melanomas. They very rarely spread far away from where they are. So if you have a basal cell cancer on your shoulder, it's extremely unlikely that we're going to find a basal cell cancer in your lung. Okay, so they don't behave in that way. But the problem with basal cell cancers is they'll often slowly just keep getting bigger and bigger and bigger and eat away at the tissue where they are. So I think the key thing with basal cells is you want to find them early, because sometimes we can treat them with something that isn't surgery, but they can still cause significant harm. If they're on a nose, if they're on an eyelid, if they're on an ear, if they're on a lip or upper lip, you can end up with fairly significant disfigurement as a consequence of these basal cells. And again, like I said, you sometimes you sort of kick yourself because you sort of go, maybe that could have been treated with a cream or a very small surgery or some other intervention that would have saved me from all this. So definitely early intervention is still worthwhile doing for all of these, and definitely the most common skin cancer by a long shot.
Oh, indeed.
Yeah.
So two main variants, superficial basal cell cancers and nodular, well maybe
Hmm.
probably worthwhile spending a little bit of time. The most common, but not by much, would be superficial basal cell cancers.
Hmm.
And those tend to more often be on the trunk, maybe upper back, shoulders, that sort of thing. And they're often just little scaly patches, little red or pink scaly patches that probably more often than not bleed a little if you irritate them.
Yeah.
And often mistaken for a little isolated patch of eczema.
Hmm.
Again, as Moses said, they grow really slowly. And sometimes, if you're having a very careful look at your skin check, you might see that the border of it is a little bit raised, or a little bit what we call a rolled border. Um, but the bleeding is bleeding of any skin spot will always make us think basal cell cancer in the first instance. Lots of skin cancers can bleed, but basal cell is a champion at that.
Yeah.
Yeah, that's the superficial ones, and they can actually get quite large. People just think they've got a patch of eczema, and we have had ones that are sort of the size of my hand. We literally have had ones that are that large, which is difficult to treat.
My most memorable one was a bloke that had a basal cell cancer that was essentially about 15 centimeters across his chest. And he said 12 years ago somebody biopsied it, and he didn't hear back from them. So he assumed it was a nothing. And so it had just been sitting there growing over the course of 12 years. And, slow growing, doesn't spread. That's great. But he's just ended up with a giant hole across his chest to deal with this
Yeah.
cancer. So, yep, definitely get something checked out if it's been more than 4 weeks, and follow up with your doctor to find out what it
Well,
was.
that's right. Yeah, please, if you have a biopsy, get your result and persevere if you have to.
Yeah.
Um, okay, nodular basal cell cancers. What about
Mhm.
those, Moz?
Often a little lump rather than a sort of scaly patch. They can be, again, sort of that pink or red color. Sometimes they can have a little bit of white to them. They can have a little bit of a crust. They can get ulcerated and, again, bleed. Like you've said, basal cell cancers are champions at doing that. They're often really well defined, so you can sort
Mm,
of see that there's a thing there. And often when they're very early on in the piece, they sort of look like those fleshy moles that you get
mm,
on your face. And so if you've got a new lump that's sort of skin colored or white or pink or red, well worth making sure that you get someone to have a little look at it if it's sort of been lingering
mm.
around. And again, not considered a particularly aggressive type, and again has good treatment outcomes. But we need to treat it. If
Me
you
too.
don't treat it, it'll
Um,
just slowly keep getting bigger.
yeah. So they often look a little bit shiny, although of course, if they have
Mm,
bled and have got a scab over the sheen will not be evident to you. And the other thing to say about these is that they're particularly common on the head and neck, and
mm,
annoyingly, they often occur where we would call embryonic fusion planes. What the hell is that? Basically, it's where different bits of the face meet the rest of it. So where your nose meets your face, that's an area. Are
yeah.
you laughing at embryonic fusion planes, Dr.
Yeah,
Moz?
yeah, yeah,
Yeah,
yeah,
yeah,
yeah,
yeah.
absolutely.
So basically, where the your face has got different features and where the different bits join onto each other. So you have to actually get in and around and look at the creases round about
Mm,
your nose. You have to look at where your skin lip becomes your red lip. You need to look there, and you also have to look specifically at the edge of your eyelid, because
hmm.
we that's when we do a skin check, we expressly check that area because nodular basal cell cancers are super common there. I mean, I think in the
Hmm.
last few years we must have had last 2 years we'd have at least 6 between us, wouldn't we? Basal cell
Absolutely,
cancers
yeah.
on the lid line.
Hmm.
So which is a lot of basal cell cancers, and that would be an area where basal cell cancer is a big problem if you don't get it, because they invade locally. But what's local to that basal cell cancer? The eye. Yeah,
Your eyeball. Yeah,
yeah. And you
absolutely. We
sadly
don't
have
want to
had
lose that.
a patient who has an artificial eye because of invasive basal cell cancer, haven't you? Yeah.
Indeed, it's a small world, and want to be very careful around that. But definitely very, very very miserable to have what
Mm.
essentially could have been treatable early, and then find that all of a sudden you've lost an eye, lost a nose, lost an ear.
Yeah.
It's really
Very
upsetting.
sad. Yep.
Yeah,
Like as you said last week, doesn't kill you but can be super life changing. Yeah.
yeah,
So they're often just like little pimples that don't resolve, and that bleed. So
yeah.
anything that ticks that box, bring it to us. We will have a little look at it.
And if we've been clever this week, Dr. Anne, hopefully there'll have been some photos of some of these things popping up as we
Oh
chat.
yeah, I think so. That's a good point. So Dr.
Mm.
Moz is collating some pictures. So even if you usually just listen into the podcast, there is video available on YouTube and certainly on Spotify podcast. Is it on Apple as yet, Dr. Moz? I've never yet been able to work
I
out
think the
how.
video is available on Apple, and I think the video is available on Spotify. I've got to be honest; I've been really lazy and I've not put it on YouTube. But this episode, I think, is really important visually, and so we'll try and make sure that it's available on YouTube as well as Apple and Spotify.
So if you can,
And I think if you
it.
usually listen, this one's a good one to actually, even if you just clock in and just skip through forward to have a little look at the photos, it is worthwhile having a little look to see what you're looking for.
Yep, and it's definitely the video is definitely available on Spotify because I can access that
Definitely.
easily. But I seem to lack the technological expertise to work out how to get it on Apple.
I've managed on Apple.
Yeah.
But, yeah.
Okay. So for completeness, we'll mention there's a third type. Of course, there's lots of types, but we lump the other rarer subtypes into the aggressive basal cell cancers, and they're really hard to spot even for us because they're very, very subtle. They often look sort of like a little scar, a little area of skin thickening, often white, just changing the quality or texture of the skin. And so if you have a little scar that you have no recollection, if you find when you're doing a skin check, that you have a little scar and you have no recollection of a trauma, it's worth thinking about getting that checked out, or at least keeping an eye on it to see if it appears to be changing over time, because that would be an odd thing for a healed wound to do, to continue to change.
So definitely a scar that you don't remember how the hell it got there that keeps getting bigger is very weird. So that's definitely an excellent description, Dr. Anne.
Incredibly subtle. Yeah.
Yeah.
Okay. Squamous cell cancer. Shall we talk about those next?
So this is sort of the Goldilocks in the middle between melanoma and basal cells. So a little bit less common compared to basal cells, but not as rare as melanomas. I still don't want, I'd rather have a squamous cell than a melanoma, but squamous cells can also be really miserable. They are often really quick to grow. They often sort of double in size within the space of a few weeks. They do have the potential for spread, and occasionally they need more aggressive treatment than, just cutting it out. There are some instances of people needing radiation therapy or fancy immunotherapy to try and sort of manage these. And they can be a significant contributor to loss of life, unfortunately. So another angry version of a skin cancer.
Yeah. So we'll start with the less worrying version and then move on. So the less worrying version would be squamous cell carcinoma in situ, also called Bowen's disease. And basically that's a really early version where the cancer is limited to the top layer of the skin. Yeah. And interestingly, that looks quite, to the naked eye, quite like a superficial basal cell cancer. So it's a little scaly patch on your skin that never actually goes away. There's usually a little bit more scale than with a superficial basal cell cancer. The superficial basal cell cancer usually is more crust because it's been oozing like eczema does, whereas the squamous cell cancer in situ would be scale. But the difference might be lost on you guys. It's also a little bit more like psoriasis than eczema, but it's a little skin patch that doesn't heal. And if you have a single patch of what you believe to be psoriasis or eczema, that should be checked out, because for both eczema and psoriasis, it's odd just to have the one patch on your body. Very, very ordinary.
And there are numerous treatments options for this that include surgery, but a bunch of non-surgical options as well. And the problem is, if we don't treat it at this stage, it's really disappointing, because it does have roughly a 5% per annum risk of progressing to an angrier version. Yeah. And so at that point, we'll have our hand forced, and we must, cut out the more aggressive types. But if we have this Bowen's or squamous cell cancer in situ variant of the disease, definitely well worthwhile, popping in and saying hello.
Yeah, the superficial basal cell cancers are in the same category that if we catch your cancer, not the melanoma, but if you catch your basal cell or squamous cell cancer when it's just limited to the top layer of the skin, there are treatments other than fully cutting the thing out down to the fat and stitching it together, including noxious cream for many people. So great to catch it when it's at that time.
Yeah.
Invasive squamous cell cancers, we see quite a lot of it in situ, but there actually is quite a lot of invasive as well, because of course there are at least two different variations on the invasive. So maybe talk about the keratoacanthoma, which is a super interesting little cancer. Yeah,
it is. Yeah, so it essentially is a weird, scaly, crusty lump, usually with a central crater or a divot, that on paper can erupt and get really big and then potentially shrink up of its own accord without causing you any grief. The problem is it looks just like an invasive squamous cell cancer. And when we look at it with the naked eye, when we look at it with a dermatoscope, when we send it off to the lab, sometimes it's really hard to tell which one's which. And so we basically just treat them like squamous cell cancers. Is that?
For your safety, we treat them as if
Yeah.
they were, because otherwise you're watching and waiting. If you're in the past, it was in vogue, before we were working as skin cancer doctors, to just let them burn themselves out and deal with them if they didn't. But they would often leave a really ugly little scar. Also, if you've got it wrong, it seems a little bit mad to be monitoring a potentially aggressive cancer, because that's the hallmark of they erupt really quickly. They develop often over a course of a few weeks, and they're sore. Yeah, they're tender and painful. Yeah.
Dear patient, you have a thing that I think is harmless and will go away, but looks exactly like a thing that might spread and go to far away parts of your body and potentially kill you. I'm just going to do nothing. That in 2024 or future sounds extremely like an unnecessary risk to take, to be honest. And if I had one on me, I'd want it gone. Like,
off with its head, I think.
Yeah.
So, but it's super interesting, and as you said, impossible to tell at any level between that and what we call a well-differentiated squamous cell cancer, which looks exactly the same.
People often get surprised by that whole, like, hey, when you send it to the lab, they're confused, because when we send it to the lab, it's not some magic computer that is deciding what the thing is. It's a human being that's looking, and so they're looking down the barrel of a microscope and trying to find the features that make them tell us whether it's a keratoacanthoma, this thing that's going to come and go without causing you any harm, or a squamous cell cancer, and they can get it wrong. And so sometimes we'll see these reports, I'm sure you've seen them as well, Dr. Anne, where they go, it could be both.
And I think it's probably sobering for the audience, because we all love certainty. So I think the general public, you would like to think that you get a definite answer from the pathologist, but the reality is that you're getting a considered opinion every time. There is nothing really that is black and white in skin cancer medicine, or indeed in cancer medicine, and you're getting the opinion of a highly trained professional, but every time it's an opinion, and when they're giving that opinion, what they are trying to do is to predict the biology of that lesion, try to predict what would happen if we left it where it was.
And maybe we'll talk about this a little bit more next week, but that again, not to whatever, but I think it makes it doubly important that the person that's cutting out the spot actually also knows what they're doing as well. Because if you have a clear and obvious squamous cell cancer and the lab comes back and says, oh, there's some sun damage change, then there's been an issue. They've looked at the wrong specimen, or they've not cut it through enough, or whatever the case is. So it's often helpful for one human, the person who's cutting it out, to be able to talk to the other human, the person looking underneath the microscope, and say, dear colleague, I think that the story is X, Y, Z. Could you have another look? And it's not unusual for us several times a year to have a conversation that looks like that. And that's not that the lab is making an error. That's just the way, medicine works. I think
we'll talk a bit more about next week, about how that works. But you're having a very good working relationship with your pathologist, where you do call them and talk about things, and you share pictures. We share our clinical pictures. They will sometimes send us the slides. God bless them. Is it because I think they think we're potentially a little more proficient at looking at histopathological slides than we are. But we share our pictures. They share, and we have a conversation. And if the person looking after your skin doesn't work regularly with the same pathologist and doesn't have a relationship, then that is concerning. Again, this is probably a topic for next week. Because it is an opinion rather than a yes or no, sadly.
So we covered keratoacanthomas. We're just chatting about well-differentiated squamous cell cancers, which look exactly like the keratoacanthomas, except for they will get angrier and angrier over time and grow quickly.
And I suppose the other thing we maybe haven't highlighted about squamous cell cancers is that once they become invasive, so not the Bones disease variation, but once they become invasive, it's quite usual for them to be a bit tender, or even painful. So it's a useful thing when you're
which would count as a change.
It would count as a change, yeah. So symptoms are a change too, yeah. So if something is sore that didn't used to be sore, or I guess careful with Lyme. So if something I regard sore as when it's uncomfortable when I'm not doing anything, yeah. But tenderness, it would be distinct from that. Would mean that if you touch it or press it, it's sore. But either of these things apply, then that's concerning, and we want to know about it. Yeah.
Yeah. Yep.
So there are much more rare, poorly differentiated squamous cell cancer, and without diving too deep in it, the well differentiated and poorly differentiated just means that when the pathologist is looking at it, how much the cancer cells look like the original benign cells that they started off being. So poorly differentiated means they don't look anything like it at all. But those are interesting, fast growing, red or pink lumps usually. We can't actually tell the difference between those even with our dermatoscope, those and a nasty melanoma or other rare things like Merkel cell cancer. But basically, if you have a fast-growing pink lump, we are going to want to remove it. Lumpus pincus, I think, is our irreverent name for these things. It just it's a pink lump. We don't know what it is, but we know it's going to get off your skin really fast.
Yeah.
Any more things about squamous cell cancer at any level, Moz?
No, I think we've covered them again. Hopefully we'll have some photos rolling around. I think that's sort of most of the chat that we wanted to have around sort of what we're looking for. Yeah, so do you want to add anything else in terms of skin checks and self-awareness, Dr. N?
Yeah, so whilst you're looking at your skin, I'd like you to have a clear-eyed look, and particularly look at the difference between the skin that's being covered most of the time to the skin that has been exposed to the sun, and have an honest look at how much pigmentation you have, how wrinkly the skin is that's been exposed to the sun, and whether you've got lots of little white spots that show where the skin is just exhausted from making pigment, whether you've got some of that solar elastosis we were talking about last week, which was the crisscrossy, thickened, waxy skin, because all of that means that those areas of skin are getting far more sun than they like, and that maybe you need to be paying a little more attention with your sunscreen. Yeah, and sometimes with your clothes off and looking at your skin, that becomes really evident to you. So even just putting your arm against your tummy, and you're like, oh, well, that looks like two different people. Yeah, two different skin-colored people, and often two people of very different ages. So sunscreen will be your friend, and have a think about that.
Absolutely.
All I wanted to say whilst you're there. What about you, Moz? Anything to add?
No, I think we've covered quite a bit of ground. A longer episode today, but hopefully one that people will have found helpful. So if you have found this helpful, pretty please do share it with people around you, and spread the link far and wide. We really do genuinely want to be a tool of change and of value for the people in the communities that we serve. And so I think if you think this is a helpful thing for other people to know, please do share it around so that they can hopefully get the information that helps potentially save their life. On a more selfish note, make sure that you rate us 5 stars on Spotify, Apple Podcasts, all those things. And follow us on the socials so you can keep abreast of the latest episodes. Dr. Anne, thank you very much for your time this week. Appreciate it.
And thanks for yours, Dr. Moz. And now, thank you for your work, because I know you're going to make sure that we've got good video and some photos this week. So no pressure, so that people can actually see what they look like.
So if you're listening this far in and the video and the photos are rubbish, you can feel free to let me know.
Oh yeah, and thank everyone again for the feedback, because feedback is really useful.
Indeed.
We are baby podcasters, and we are very much learning, and so it's good to get some feedback.
Absolutely.
On what's working and what's not working. Yeah. Okay. Have a
week,
good week,
Dr.
Dr. Moz. Skin Cancer Part 3 next week. Eh? Take care.
Take care. Bye now.